What does a meniscus tear look like arthroscopically versus on MRI?
So let's take a look. This is the meniscus on the model, top bone, bottom bone, articular cartilage, and the ends of the bone, what's like a eggshell, and the meniscus. The meniscus is this cushion, and the meniscus can potentially tear like this. And then we can see that, arthroscopically as well. So this is a relatively normal looking meniscus, nice and flat. But over here you can see how there's a tear going right through here and how this edge is now suddenly jagged. And so you can do the tear going through there. And then it even extends under here as well. And an MRI view, this is a side view. If we're looking this way, and you can see the meniscus really should, this is the front portion, this is the back portion. It should be full and solid like this. And here you can see the line going right through it. And here's the front view again. See that this is one meniscus, the lateral meniscus. It's nice and solid and full. But over here, there's a big line, a white line, tear that's going right through it. And again, here's the side view going right through it.
Tunnel placement. You've called it the most critical step. What does a surgeon see or feel that tells them the tunnels are in the right place?
So, the tunnels are crucial because we need to recreate the ligament exactly where, or reattach the new ligament, exactly where the original ligament was. So it was attached up in the femur in this area here and down in the tibia. So for example, taking the femur, if we're just 2 millimeters too far anterior forward, that has shown to significantly increase the rate of re-tear because the function is never returns ideally as it should if it's not placed right back where it should be. We use the direct visualization with the arthroscope, which has a camera at the tip that has almost microscopic ability. We also use special instruments to measure where it's going to be. And ultimately, and we also know where it should be. And ultimately, once the drill hole, the tunnel is made, and we clean out all the debris and look at what's called the back wall, we should only see a couple of millimeters of bone behind it. It shouldn't be less, and it shouldn't be more. If we see there's 4, 5, 6 millimeters of bone behind the back wall, what's called the back wall of the tunnel, it means we drilled it way too anterior. If it was drilled, if the back wall is tiny and thin, or it's blown out completely, which some people have, it's occurred to some people, then the tunnel was drilled too posterior, too far in the back. There are things you need to do to correct those things intraoperatively if it occurs, but it's absolutely crucial to get it in the right spot. And it's ideal to get in the right spot the first time and not have to keep correcting it.
What does graft tensioning mean, and what goes wrong when it's set incorrectly?
So the graft regains its function essentially two ways, but really ideally it regains its function when you put it anatomically. If you put it back in the right spot, its function and its strength should come back appropriately. But what happens is that once the fixation up in the femur is done, we go to the fixation in the tibia, and what we do is we typically pull down on the graft to achieve a certain tension. You don't want to pull too hard because then it'll make the graft too tight, and that might make the patient stiff or have a risk of re-tear. You don't want to make it too loose because then it'll be kind of floppy and it won't regain its full tension. So you want to do it just right, and that's a matter of experience. So the tensioning, there are some gauges you could use, but ultimately there hasn't really been all that used. The tension is important, but what's probably most important is the tunnels being in an anatomical position.
How do you know intraoperatively that the tension is right?
We probe it. Once the tension is fixed and the screw is fixed, we look back inside and we probe it. And when we probe it, meaning that we take an instrument and we pull on the ACL. When we pull on the ACL, it should be like this. It should have some kind of tension to it. It shouldn't just be floppy and loose. If we go back in and we see that it's loose, we probably will retension it.
Is this the most technically demanding moment of the procedure?
I probably would say the most technically demanding moment of the procedure would be the tunnel placement.
What does the knee feel like at the end of surgery when everything went correctly?
Feels great. It feels like patients come back 2-3 years later, I know, with other complaints, and they don't. Sometimes they forget which knee was done. So if everything is done right, and once you recover, it's not a road through a rose garden, but we make it as comfortable and as comfortable as can be. But ultimately, once you fully recover, you go back to your life. People go back to professional sports. Patients going back to professional sports, going back to collegiate sports, recreational sports, mining, building homes. People go back to anything they need once everything is done right. It's wonderful.
What should a patient call their surgeon about in the first 24 hours after surgery, and what is normal?
Well, the patient really should feel comfortable calling their surgeon about anything they feel they need to talk to their surgeon about. You should feel comfortable about that. But probably the big things to look out for is fevers, extreme drainage, bleeding excessively if your dressings get very damp, excessive pain, dizziness, things like that. But for the most part, you should feel comfortable reaching out to your doctor whenever you like.
You said the first 6 weeks are the most vulnerable for the graft. What is biologically happening during that time?
So at that time, the most critical part or portion of the fixation healing is happening. Immediately after the surgery in the first 6 weeks, that ACL graft is held on primarily by the screws that we put in to hold it. But as time goes on, the graft starts connecting to the bone. And the more time you give it, the greater connection there is. And after about 4 to 6 months, or rather 4 to 6 weeks, it's relatively safe now to take off the brace. So we use the brace in the beginning, and we ask you to be cautious with your weight bearing in the beginning, and we use crutches in the beginning because of that sensitive period, because the graft has not started incorporating into the bone and becoming part of your body as of yet. And it's only relying on the screws. So we want to be as careful and as cautious as possible during that time.
What would cause the graft to fail in those first 6 weeks?
It's unusual, but patients might start going and doing things becoming very overly active during those 6 weeks, not using their crutches, taking off their brace, running, jumping, pivoting. Those things should not be done during the first 6 weeks after ACL surgery.
What outcome tells you the surgery went exactly as planned?
So we take we do a lot of very close monitoring of you, the patient, during the entire process. So we check on you after the surgery. A couple of days later, we give you a call, see how things going, and we see a week later. We examine you, and on examination, we look to make sure everything is healing and looking healed. We examine you, make sure that the knee is stable. We examine your knee to determine if it's stable. We also do an X-ray. Sometimes surgeons will use absorbable anchors, and sometimes doctors will use metal anchors, but you can still see the tunnels on the x-rays. So we usually get an x-ray and we look to see proper tunnel placement on the x-ray, and if a metal screw is used, we can see if the screw is in the proper position, and we monitor you on a regular basis.
What is the one thing you wish every patient understood about the post-operative period?
I think it's a matter of patience, and knowing that the horizon, good things are to come. If you abide by the important rules and guidelines of the recovery, which are not as stringent as you might think, then the recovery should go just fine, and you should do very, very well. So it's a matter of crutches and a brace the first first month, steady progression during the course of the recovery. Usually we do some light jogging after a couple of months. We can do some non-impact training after that, then gradual straight running without pivoting. And we continue to progress. Most patients, in the beginning, there's a bit of an anxiety, but once they've gone through the course, they're very, very happy and satisfied. If you've been told you need ACL surgery, or you suspect that you need ACL surgery, and you're not sure as what the whole process is, and you haven't really been fully informed, or you're not sure, and you just want to know, it's important for you to know because you're considering surgery, come to New York Bone and Joint Specialists. We will give you absolutely every detail of step by step what's involved, and we will make sure that you will understand what the right steps are, and we will take very, very good care of you during the whole process. Give us a call or click.